Thank you. So, hello again. So I'm presenting this patient, 72 years old gentleman, who was admitted with heart failure, basically. Had a past medical history of severe aortic stenosis, diagnosed in 2014. At that time, he had TAVI done with the Medtronic core valve, number 26. He had an echo in the following years. His 2017 showed a mean gradient of 16. In 2021, the mean gradient was 24. And in 2022, the mean gradient was 32. And I have in my encounter with this patient in 2023. So also he had a leadless pacemaker in 2017, proceeded with left bundle at that time, dyslipidemia, hypertension, type 2 diabetes. This is his echocardiogram when he was admitted with heart failure to us. What you can notice right away is that the valve seems to extend slightly into the LVOT, so it's a deep implantation. The mitral valve looks okay. There's no clear AI that we can see of valvular leak or mitral regurgitation. Also, in the short axis, we could see a central AI that's as clear as we can see, but nothing major in terms of other finding. The mean gradient for this patient is about 34, but the velocity is almost reaching 4 meters per second. So we are hinging on the severe form of aortic stenosis in a TAVI valve. This is a 5-chamber view showing just the central AI. So the final report, the LVOT, the valve is placed slightly in the LVOT, mean gradient of 33. The Vmax is 4 meter per second, and the DVI is 0.3 meter per second, and the effective orifice area is about 1.3, considering an LVOT of 2.2 centimeters. Mild intervalvular regurgitation, normal LV function, and no regional motion abnormalities, and the right side it is fine, the right side the RV, and there no pulmonary hypertension. We did a coronary angiogram to show what the coronary likes, and this is the diagnostic. So right is dominant, no significant disease in the right. You could actually appreciate the leadless pacemaker. The left system is also fine, so no coronary artery disease per se. Okay, the CT scan, we did a CT scan, and we assessed the transcatheter heart valve, the THV, and basically at the LVOT you can see it's wider, its perimeter is 69, while at the annulus itself it seems to be underexpanded a little bit with a perimeter of 66. The area is 342 versus 366. When we look at the coronary height, the left coronary height from what is supposed to be the annulus is about 17 millimeter, while the right is about 13 millimeters. And what we can see that the VTC for the left coronary artery is 6.4, and for the right is 3.2. Both of them are in the safe zone. What we've noticed, as you can see, especially on the right side here, as a point here, that there is a significant calcium nodule there, and it's preventing the valve from expanding. It's basically present at the junction between the none and the left coronary cusp. Okay. And with simulation of size 23S, Sapien 323, we can see that it's a good size. And in terms of the height of the coronaries, it will be landing below the left main, but the RCA will be around that area. Okay. In terms of peripheral axis, we have a good peripheral axis, no significant stenosis, no significant calcification, and no significant tortuosity. So the finding, as mentioned, I didn't show you the STJ, but it's average diameter of 24.4. And there is incomplete frame expansion of the THV because of the calcification. There is also some element of HALT, or subclinical leaflet thrombosis. And the implantation depth of the current core valve is about 6.6 millimeter into the LVOT. And the VTC are more than 2.5 on both sides, and the height is just good. So the risk of coronary occlusion based on that is low, but you have to take in consideration what valve you're implanting and what's the height of the new skirt if you are going to put a valve in valve. So those are points for discussion. I will hand it over to my colleagues in the panels to take over, but those are the things that I have to discuss myself and with my team before going forward and what's the option. Thank you.
Thank you, Abdulrahman. It's like amazing, elegantly presented. So let's start around the table, Dr. Terena. So you saw the case, you saw the CT, the echo, so you saw the coronary, so you have no objection or any remarks. What do you think? What is the next step? Should we send the patient for a redo TAVR with explantation or go for percutaneous options?
I would go third. I'm always a contrarian. But I think if there's some halt, a component of halt, I would try him on some anticoagulation. The valve area is not super severe at this point. Unless the patient clinically is just not able to be stabilized, I would try him on anticoagulation for a few months. If you can buy another year or two from this valve, great. So that would be my first step. But assuming we did all that and we're ready to go, I think this is a perfect candidate for a redo. I think we need to expand the valve. There's a little bit of risk, but it looked like it was more iridomitral curtain, the calcium, so a little bit lower risk for annular rupture, and I would dilate it well, the prior existing frame, and I would go with the balloon expandable valve.
So, Dr. Ali, thoughts now. Let's say we're going now with a percutaneous option. Are you going to dilate? Are you going to use a short frame, long frame? What is your thoughts?
So I think definitely I'm going to say yes for pre-dilatation, because crossing those valves, and they're not as easy as crossing native AS, and you can get caught with frame and old stents. Now, in terms of valve choice, the RCA height is borderline. And I think with the self-expanding valve, you may run into problems in terms of coronary obstruction. I would think of a short frame valve. A 23 sapien would be my choice in this case. I would pre-dilate and potentially post-dilate. This patient has a pacemaker already in situ, so that's going to help in terms of depth of implant. So you're not really concerned about going deeper than usual and protecting the right coronary artery. The other thing I would do is, when implanting the valve-in-valve for this case, I would consider using an RCA implant view, where I look at the RCA ostium at the time of implanting the valve-in-valve, and you can use that to land your sapien valve just at or below the RCA, and in doing that, you can assure you're really avoiding the coronary ostium, and you're not really concerned about coronary obstruction.
Dr. Hussein, what about you? Most of we have here talking about short frame valve. Any thoughts about the implantation strategy? Are you going to use an extra wire, crossability? How going to you tackle this, in terms of the crossing and the positioning?
Yeah, I think in terms of crossing, probably you have to cross with a small big tail catheter, probably it's better with a wire support, so that you make sure you don't go through the struts of the stent. In terms of pre-dilatation, it depends on what valve you will use. If you will use a self-expandable, I will pre-dilate. If not, then the balloon expandable valve will take care of that. Because pre-dilatation, there's a risk of dislodgement, there's a risk of embolization, CVA, and I think it's better to avoid it, since the balloon of the balloon expandable valve will take care of that. Definitely, I'll go below the coronary lines or coronary frame, and that's all. I don't think by the way, it's not a difficult procedure. When you have landmarks, it's much easier for you than when you don't have in native anatomy. So,
Dr. Tariq, in the last couple of questions, will you use the snare to control the previous core valve? And talking about stroke and pre-dilation, will you use a cerebral protection device in this case?
So before we get there, I think there are a couple of important concepts for TAVR and TAV. There's the concept of neoskirt and how long of a tube you actually create with the new valve. The neosinuses, the sinus is 0.24, so you have to be very cognizant of the potential for you creating a very long tube. Leaflet overhang if you implant your new TAVI deeper. Luckily for this patient, his first TAVI was implanted at 6.6 millimeters, which means that the neo skirt is not going to be that tall. You have leverage and latitude to implant your new TAVI, which I believe is probably going to be a short frame balloon expandable TAVI. I'm concerned about the calcium mass, because It probably contributed to the failure of this TAVI with inappropriate expansion and mobility of the leaflet, and this remains an issue. I'll have to think about what to do with that, whether I want to balloon it aggressively and risk annular damage or injury, or just bite the bullet and just put a valve in there. Our practice has been to do mostly cerebral protection devices. So I'm very comfortable with that. If there are no financial limitations, I would vote for that. The concept of HOLT and anticoagulation, I would be very concerned about crossing ballooning a valve with potential thrombus on it. So I would agree with option 3, if, as you mentioned. I do not usually stabilize the first TAVI with a snare. It's calcified, it's been there, it's not going anywhere.
Okay. So show us, Dr. Abdulrahman, where did you go with this? Or if you have a commentary to our comments.
Sure. Just a quick follow-up with Dr. Tariq. If you're doing long frame or basically Medtronic and a Medtronic, you would still not consider using snares?
So the only TAV and TAV approved valve in the United States is a Sapien and a Medtronic.
Sure.
So the Sapien is the only TAV and TAV. So we have done Medtronic Evolute and Evolute.
Yes.
I find that the first valve actually stabilizes the new valve, and we've not had to actually put any stabilization strategies in place. Sure. Teaching me something new.
No, it's just, I think the real challenge when you do a long frame into a long frame is the fact that the Medtronic or the long frame, you do not have a control over the tip. You cannot basically turn it in or curve it. So it will rub commonly against the frame itself. Right. And it becomes difficult. I have done a case before where I had to use it, and it was very difficult to get it in. I had to actually make sure that I stabilized the valve. Mind you, the valve was the valve was fresh, so we implanted the valve that went deep, and we had a significant paravalvular leak, and I had to remedy the situation by implanting another valve in it, but I didn't have access to a short valve at that time, so I had to go with it, and I had to stabilize it with a snare. But when I was going through it, it was not fun. It was really difficult to just cross with another TBH, another TAVI across TAVI. So I think that's something just to take into consideration.
Agree with that strategy in a fresh valve. Agree 100%.
So what we did basically, we planned to go to transfemoral. We decided that we're going to re-dilate with the 22, especially with the frame under expansion. We chose a short frame for the fact that we wanted to make sure that the new skirt height is not big. Luckily, the patient was having the valve slightly implanted in the LVOT, so that would reduce our new skirt height. Remember, the Sapien 3 has about 30 millimeter skirt height. If you add it to the core valve, if you implant it a bit high, you kind of generated a long skirt height, and that you might occlude coronaries if you have shallow sinuses. We aim for S3 to land at node 4 of the TVH of the Evolute R to reduce the new skirt height, and we were planning to consider post-dilatation with 23 if required, and closure of the right femoral axis with a single 6-French Pro-Glide, which is my practice and a practice in our center. So basically, this is the axis, is micropuncture, right femoral approach, and you could see the entry point is a good entry point. And we have taken just a picture. You could appreciate the depth of the initial TAVI. You can see how many nodes it's below the annulus level, so it's at least 4 nodes there. And we had a shorter balloon, unfortunately, at that time, but we had tried to use it to pre-dilate, but keep melon seeding, as you can see. But we get a little bit of expansion that we require. Sorry, I want to go show you this one, the other one. So you could see when we inflate, it's just, we're trying to target that point of the calcium on this area here. This is the calcium that we're seeing, and it's not working. So anyway, we brought our valve. We aim to be at the same level at the LVOT because it shrinks at the inflow part. And this is the deployment. And you can see we were at the same level, but we going higher. And you can see the shrinkage or the shortening of the S3 is at the lower part, and we deployed it there. The frame, if we notice, the frame is expanding. Look at the frame, it's expanding with this balloon and the valve. So the frame is actually getting a little bit of expanding. we were lucky enough it didn't cause anything because that calcium nodule at the junction was close enough to the left main to cause trouble. This is the calcium nodule as you can see it here. So, and this is how our valve ended up. And this is a final shot with the injection. And we can see both coronaries are open. We can see the height of the crown is just below the coronary axis, so we don't have any problem even to engage them if we need in the future. And we close our axis, the arteriotomy site, with single ProGlide. We do that, and you could see some stenosis, but the flow is good. And the outcome was successful implantation of Sapien 323 and a 26 evolutar, no coronary compromise, and no need for post-dilatation based on echo. Basically, you could see here there is no paravalvular leak, and there is the intravalvular resolved, and we could see the main gradient was 8, and there was no significant issues with that. And I think the case summary is Sapien 3 is a great option for TAVI and TAVI situation. Ability to control nose cone with deflection is very important, and that's provided with the Sapien. And we need to minimize the new skirt height when you consider NTVH, NTVH, or TAVI and TAVI, just to reduce the risk of compromising the coronaries and allowing proper access to them. And pre-dilatation is important if the valve is not well expanded. And a single ProGlide works, and if you use it and you get a hang of it, you will prefer it over to ProGlide techniques. Thank you.
Thanks, Dr. Abdulrahman.